So many of you have had the pleasure of listening to Jocelyn's talks in the past, and we're going to put her bio up in a second, and you can read that. There's a lot there, but there's probably something that you don't know about Jocelyn. She has 2 kids who play soccer, and she has an unofficial restraining order against her. She cannot be within 100 meters of the sidelines when her kids are playing soccer. She calls it encouraging them. The coaches call it yelling. Ladies and gentlemen, I'd like to invite Jocelyn Hill to come up for her speech.
So that is a true story. That was not an alternative fact. Sorry, this is not my stuff. I don't look at this one. Close it. Okay. Thank you very much. First and foremost, I would like to thank CVAA and the CVAA board members and Cheryl McDermott in red somewhere as president for allowing me to speak for putting on this conference year after year. But really, there is someone that does amazing work for this organization and for this conference specifically. And I would like to acknowledge Melissa McQueen for her excellent work for CVAA and what she does for us as an organization and members. We can always call her. She knows us by name, and so very, very personable and friendly and open. So thank you, Melissa. So my talk today, this has came from many discussions with a lot of you here, previous presentations that I've done. I live in Vancouver where there's a lot happening there when it comes to harm reduction, and it's really an epidemic. There's really a health crisis happening. So I think, I really encourage those of you that are here, because I have many discussions with you. I think all of us are dealing with this issue. I'm going to talk about some theoretical context. I'm going to talk about some strategies, some real strategies that we're seeing great success with in Vancouver. These are my speaker disclosures. I am a consultant for these companies, but they did not have any involvement in this presentation. So again, we're going to talk about harm reduction theory. I'm actually going to move over here. Can I do this? And ethics, and what that means, and the relationship between the ethics and how we practice and harm reduction. And again, I'm going to talk about some strategies that have been very successful in Vancouver. And I know across the country we're being looked at with a microscope on some of the strategies and interventions that we're implementing, that we're studying. So again, I'm just going to discuss more on that. So it really is a current event. We hear about it in the news all the time. I don't think this is a non-news event. I don't think it's an alternative fact or fake news. This specifically is in Vancouver, what I'm showing you. Most tragic year ever. BC is seeing a very, very high, volume of issues. But again, it's happening in every province. It's happening in many different cities. It's happening in many small towns. This is just not unique to Vancouver. Many people are dying. But these are our patients. These are the people that we see. Again, the trend is just going up. So I am just randomly picking things off the internet that we're seeing in the news, and all I hear about are not just deaths, but problems that we're seeing in the inpatient departments and the outpatient departments and in our communities about these, about this healthcare crisis.
I cannot live a day without using shame, guilt, anger, and resentment. That's a feeling I never want to feel again. But everybody deserves compassion and care. Know that you are worth it. Recovery is real. Recovery is possible. It takes a lot of strength and a lot of courage to be able to do it, but you can get through it.
So that's just an example of a lot of advertising, marketing, what the BC government is doing to provide support to the general public. And I think it hits home for a lot of us that work in the healthcare system, but it's really about the stigma and the negative implications when we see videos like that or when we see advertisements like that we have in our heads in our own values and how we feel as people, not as nurses, not as physicians, not as social workers. It's about who Jocelyn Hill is. But it's about the language that we're using. It's not necessarily abuse, right? It really, sometimes it's not even addiction, it's just use. A lot of times it's just use. A lot of the negative implications that we see at St. Paul's Hospital in Vancouver, it could be the one time that woman tried a substance and it was laced with fentanyl, for example. One time. She wasn't an addict, she wasn't a user, we didn't know her as a diva, it was that one time. Substance use disorder, though, is now, it is a diagnosis officially. So it's something that, we really need to reduce the stigma, change our language about it, and talk more openly about it. It's kind of like, I'm going to say, congestive heart failure. It's something that's diagnosable, treatable, and we need to sustain how we treat these patients. Another word that I've been hearing about, and again, because I'm inundated with conversations with physicians, with nurses, with staff, is overdose. We're trying to change that language because what I'm hearing is the physicians don't like that term overdose. Is it a reaction? Is it a toxicity issue? Overdose just has these negative implications in terms of language and how we view it. So the context of substance use disorder is that it's a primary chronic disease of the brain. The brain is wanting reward, motivation, memory. There's something happening there with the brain when they use substances. So it's not really about, is it a choice? Can't they do something else? Can't they just quit? It really is seen, and we're really recognizing it, especially at where we work, as it is a disorder. It is something that we need to think differently about. So just to reflect on how you're feeling as I start this presentation, what are your values about this topic? What are your ethics about this topic? Think about how you work in your daily practice. Maybe you see these types of patients, maybe you don't. What happens in your practice when you're ethically challenged, morally challenged, based on how you think when you're at home with your families, and then you go to work, and then you're dealing with an issue that makes you uncomfortable, that really challenges how you think. So at our core, we have ethics. At our practical, what we do every day, we have nursing ethics. The Canadian Nurses Association is very, very clear on what we are bound to by nurses as the foundation of our practice. And as an educator and as a leader, I'm involved with some staff issues where if they're not abiding by these core principles, we can have that discussion with the manager, with senior leadership about their practice. This is at the core of our foundation. Medical ethics. Physicians are also bound by this. So this is not new, this is not novel, but it's something that I think that we take for granted, because at our core, this is what it's about. So we have a duty to care, right? Can we all agree to that? We do have a duty to care. We don't go to work every day thinking, well, I'm not going to take care of that patient today. Or you might think it, but you have to do it. We have to take an active stance in what we're doing and being compassionate, competent, and ethical. We need to know what the social determinants of health are, what the significances are with our patients, and to promote justice. Equity is important in everything we do. So harm reduction theory, I think it's a term that gets thrown around and everybody says, oh yes, we're practicing harm reduction. Oh yes, that's harm reduction. But what is harm reduction? It's actually an old concept. It actually started in the 1960s, maybe even before that, and I'm going to talk about some harm reduction strategies that we actually use in our everyday life. It's very prevalent in the literature when it comes to illicit drug use. It's evidence-based, it's being studied everywhere. Everyone is talking about it. It was formalized in Liverpool in the UK. It really is a public health approach. So it's just not about Jocelyn in Vancouver, talking about harm reduction for St. Paul's Hospital. It is a global theory that everybody is trying to implement. But the main thing is it's here to stay, and it's about the community. It's about the individual, it's about our families, and it's about our society as a whole. So again, it's just not about Vancouver. It's just not about, the home IV program, the home TPN program. It's about everything we do in our practice and in our lives. So it is ethical. So I'm trying to link here harm reduction and ethics. It really is ethical when we think about harm reduction. And even when you think, if you don't know the details and the literature and the context, the real definitions of harm reduction, it's ethical. You're trying to reduce harm, if you just think of the simple language that it is. But when it comes to illicit drug use, it's not about abstinence all the time. And I think that's sometimes where people get lost in the message, because they assume you can reduce the most harm if you just stop using. If you just don't take the risk. Just don't do it. Now in downtown Vancouver, it can be very hard simply because of the environment and the population that's there. So there's a lot of risk for people that are either trying to quit or that are trying to experiment. There's a lot of exposure there. But it's really important to understand that harm reduction is not just about abstinence. It's really, again, social justice, equity, but what they aim to do with harm reduction is provide practical strategies to reach a goal. And the end goal is about public safety, again, community, families, individual safety. We want to keep people safe, minimize death, disease, and injury from high-risk behavior. This is really what it's all about. So I tried to pick out some key principles of harm reduction, and it was very hard to do because I think all of these are important, so I apologize for the very busy slide. Pragmatism is the most important to me because it's about just accepting. We are inundated with challenging patients, challenging situations, but we have to accept that drug use is out there. We cannot turn a blind eye to it, and I know many of you will agree. There's not many hospitals that don't see drug use in their patient population anymore. Human rights, it's about the judgment. We need to try to take that away and keep it inside, away from how we practice and treat these patients. And we need to focus on the harms, again, and not the use. So it's not about you're using, this is a problem. It's about you're using, how can I keep you safe? How can I keep my nurses safe? How can I keep the physicians safe? How can we be safe, acknowledging that they're using? We want to maximize intervention options and prioritize immediate goals. Where the person is at. This is another key element of harm reduction. So there could be someone that is, again, that one person, one time, had an overdose because of a fentanyl issue, fentanyl reaction or toxicity as the language is changing. Or it could be someone that has a history of it, that has been using over and over again and has had struggles with addiction, with abstinence. And there's a lot of theory, and we're going to talk about that, about abstinence versus harm reduction. But most important, and I think this is what's really driven home in the place that I work and in Vancouver, the city, it's about active participation of the patient. It's actually asking them, what's happening with you? Where are you at with your drug use? How can I help you? It's not about me saying, well, I'm going to do this, this, and this. And these are my expectations. These are the rules of the hospital, for example. It's actually about questioning them, involving them in the conversation. It's about empowering these patients that we're seeing that are struggling. It becomes about them and not about the hospital and not about our rules and not about our criteria for accepting or you not accepting them into a program. So again, this is a big debate, very controversial. We have a lot of conservatives in our province who feel they just need to stop. They need to go to the programs that'll make them stop. How that happens, it's not very successful depending on the situation. Harm reduction actually works with the individual, works within the community if they're having a rash of incidents or a rash of deaths or overdoses, to try to meet the needs and safety issues of the community, and again, of our families, of the people that we see. The overdoses and the drug use is happening on school grounds. It's happening in parks. It's happening in not just alleyways, but it's happening everywhere. Public space is an issue. So what is our relevance? Our patients, again, the trend is growing. We're seeing higher numbers of these types of patients. Our emergency departments are inundated with these challenges. There's disruptions in care, against medical advice. It's a very common term. With harm reduction theory, we're trying to get away from it against medical advice. If they don't show up for 3 days or 3 visits, it's actually okay. I know a lot of hospitals would, sometimes I get calls from other clinicians and they say, well, they don't meet the criteria. I don't know where they are. They haven't shown up. At St. Paul's, that's not our policy. We're going to enact some security issues. We're going to engage with the local police. We're going to try to find them because it's about them, not about my bed on the medical unit, kind of is, but, not about the bed on the medical unit that they're holding and they're not there. But, inadequate care because of this issue. Are we meeting the demands and expectations? This is my question, and this is what I would like you to think about. Are you, in your practice, meeting that demand?
Yesterday we had someone come back 7 times in one day, getting Narcan in the community or here every single time. So it can get overwhelming. It can get to the point where you're just like, why are we doing this? This is getting too much. But at the end of the day, when I actually saw him at the end, he's like, I really need to do something about it. So occasionally you can break through and you can find that one moment. Everyone has their limit of how much they can handle, and perhaps I haven't seen him today, so perhaps he is getting a little bit better. So you just hope.
So that was Tanya. She is my clinical nurse leader and educator in my emergency department at St. Paul's Hospital. She is amazing. And again, that's her being interviewed on CBC News, not by me, not by St. Paul's Hospital, Providence Healthcare. I mean, this is a national recognition for Tanya herself, her staff, what they deal with. And again, what she's saying is relevant and real. 7 times, whereas they know the person. They know what he's on. They know what type of line he has. They know he's actually alerted as a diva, difficult access. They know where they're not gonna go with the IV, but they're always expecting. It's kind of like being a mom waiting for your daughter to come home. She's gonna come home, right? The harm reduction spectrum, I just wanna provide you some insight again about a spectrum. And Cheryl talked about Insight, and we did have a presentation. It wasn't by me, actually. It was by someone from Insight in Vancouver. And this was, I think, 8 years ago, 7 or 8 years ago. So again, not new, not novel. But from what I understand, there's not a lot of safe injection sites or needle exchanges across the country. Is that correct? Do you have one in your province, city, town? Yes? Good. So when we did the presentation, he was the clinical nurse leader from Insight. There were 0. Everybody was saying no, no, no. Vancouver was one of the first. So now there's more. But in terms of something like Insight, it's obviously no harm. They're going to stop, they're going to quit, or they're not using it all. Is that reasonable? I don't think today we can say that's reasonable. Lesser harm going to Insight. There's still risk at Insight in Vancouver, don't get me wrong. It's in a location, geographically, it's in an area of risk. The population around there, the geography around there provides exposure and risk. More harm, using sterile needles again. Okay, I'm providing them sterile needles. Are they reusing them? Right? I can provide them, and we actually do provide them, which is a strategy I'm going to talk about. But the most harm is about sharing and using dirty needles over and over and over again. So just to give you some insight on what a spectrum would look like. So again, harm reduction, not new, not novel, also in the general public. So it's sunny out. There's sun. What is a harm reduction strategy? Sunscreen. Who rides a bike? Helmets. So again, it's so basic, right? Who drives a car? Seatbelts, airbags. Who's engaged in extracurricular activities? Okay, this is just a bit. Hopefully. So our world, vascular access and infusion therapy. What do we see? We see infections. We see challenges. We see medications and therapies that aren't so great on the veins. I was just talking to Dr. Ledun, and we were talking last night over dinner about penicillin G. How many people give Pen G in their home IV programs, IV programs? Dr. Ledun says they don't give Pen G in the US. How is that?
I haven't given it in 20 years.
So, despite the cross-border issue, we're doing a lot of therapies. We're seeing a lot of challenges. TPN, chemotherapy. just in case IVs, as Shelley and Russ were talking about. You know, for hydration, for other medications. So sometimes it's just not about their osteomyelitis, their endocarditis that we're dealing with their infection. These patients are very complex now. So it all starts great, right? Lovely veins on the forearm, on the outer aspect of the forearm, nice and palpable and healthy. But then the fun starts. And these are photos that I've received with permission from patients that have had multiple IV pokes, obviously, that you see, complications after removal. You know, and then we add IV drug use. Again, real photos, and I'm sure you're all saying, yep, seen it, dealt with it, been there, done that. And then a tattoo. We used to have these lovely little tattoos, little Canada flag right here, little thing right here. Now we're going full out, full arm, full body, full chest, full color, the colors, the intricacies, the detail. It's an art, it's amazing. But I'm trying to find a vein there. They come into the emergency department, and my IV team, paramedics have tried, emergency staff have tried, but now the IV team come and we've got to start an IV. So technology can help. Right? Ultrasound, we're all very good at talking about ultrasound, but are you competent? Are you confident with ultrasound? I think putting that toy in your hand, and I do call it a toy because some of us aren't as proficient and competent with it as we'd like to be, right? The one above is a vein visualization strategy. We actually use one that's on the head, so it can help with how you navigate and helps with the population and the environment that we are in. So it's not, you know, the footprint is smaller in the emergency department, for example. But technology can help if you know how to use it. And then most of you have seen this slide before, but I always bring it up because it keeps happening. I thought I could delete it from my slide deck and say, oh no, it's all good. We're not having an issue with occlusions in the other category. So for those of you that may or may not remember, the one on the far, this one, anybody remember what that is? I have found this in a Picc Line. It's antifreeze. Okay, this one, the red one. Again, I have seen this in a Picc Line. NyQuil. These two, maybe a bit more obvious. The blue one, crystal meth. And the white one, crack cocaine. So these are things we see. I think the most surprising ones are these two, right? Antifreeze, and yes, they instantly go on acute dialysis, instantly in the ICU, but it keeps happening. I'd love to remove this from my slide deck, and I can't because I just had NyQuil again, and it was like this sticky substance in the Picc Line, and I got called down, and my IV team didn't know what it was, and I said, oh yeah, you can smell it, right, when you take the cap off, so the fumes. So we have challenges, right? Let's accept it and let's talk about it and listen to presentations and attend workshops and really try to be engaged and involved in some of the solutions and strategies to try to deal with it. We have our repeat offenders, which is very negative language, but I hear it all the time. Visitors or clients is a bit nicer language that we can use over and over and over. And I get this a lot from my Picc team especially. How much is too much? They're back again. They went AMA again. This is their third time again. Same antibiotics. But it's interesting because the infectious disease physicians don't seem to struggle with the ethical question. They're like, okay, Jocelyn, he's back. Let's move on. Let's get on with it. We need to treat everyone the same with the same treatment. So we're good at what we do. We can get them in. Better technology, better products. Our toolboxes are full with innovation and products that can really help us. But still, devices fail, right? Patients do not comply, and they do not complete therapy. So that's an issue. Again, for the greater good, not just of the patient, but in general, for our repeat visits, for our length of stay, for our hospital admissions. So this is a slide you might have seen. It's a very popular slide used by harm reduction, infectious diseases, social workers use this, and it's about, I like it because it talks about, it kind of represents how we treat people. Is it equal? So we're providing everybody that Picc Line, right? Everyone gets that Picc Line. But if you notice the little guy here, he has a Picc Line, but he's not receiving his full therapy, for example. He's really not. So maybe we go to, we go to here, or maybe he doesn't get a Picc Line, maybe he gets a tunneled line, and he's able to complete therapy because it's easier for him to manage. It's safer for him to manage. And then, of course, the reality is there are some people that we may prejudge or force our values on, and they get everything, right? They get the private room. They get to see the physician first on the list in the OPAD departments. I mean, this really happens. This is what I see, right? Based on who they are, based on who they know, they get more boxes than this guy down here. That's the reality. And I think this is our constant struggle. So what can we do? Of course, we can collaborate. And I like the term collaboration, but sometimes I think it's too fluffy, because obviously we're going to collaborate. I mean, I'm very fortunate, we are very fortunate, those of us in Vancouver, we have a plethora of resources to call, to talk to. Addictions medicine, we actually have a whole specialty on addictions medicine. Psychiatry, very, very involved and engaged. Social worker, ID, antimicrobial stewardship, obviously. The family practice physicians when we can find them. But the ones that are engaged and involved are very, very engaged and involved. And then of course, our community, and that's one of the strategies I'm going to focus on for Vancouver. But I wanted to highlight, the police, the RCMP, the Vancouver City Police, and our security services team. Now, our security team, we actually privatized. So it used to be part of the hospital, and I think many of our other hospitals have gone through this, where now they're a private company. They're not actually employees of the hospital. And at first it was tough, it was challenging. There was always this silo that they were practicing and working in one area and we were working in other. But again, the collaboration, that fluffy word, we're actually working really well together in trying to meet the needs, not just of the patients, but of the staff safety. Staff safety is very, very important. So back to vascular access, we need to choose wisely. And again, we have a plethora of tools in our toolboxes. There's tons of stuff we can choose from. The peripheral IV, the long peripheral IV, the midline, the Picc, the tunneled line, the IVAD. We need to choose our sites wisely. So someone, there may be a certain patient, it's not going to be appropriate for them to have a Picc line in the upper arm. It might be more appropriate for them to have it in the chest, and that it's tunneled. And traditionally, we wouldn't do that for 6-week therapy, traditionally. But maybe we need to think outside of the box, because in order for this patient to complete their therapy and to be compliant, it just might be required. We need to secure that sucker, whatever we're doing. Dr. Ladon showed some great photos about dressing, disruption, and everything. But when we have the perfect dressings and the securement devices, we need to make sure they stay that way. We're utilizing technology, a subcutaneous engineered securement device, very, very successful. And I have it now that the home care nurses or the community services are saying to me, they have to have this on. They have to have it on. Of course, it could still come out. The patients are still risky and they're still chaotic in their behavior, etc. But it just gives the staff that sense of security. And there are other methods to secure the line. That I'm showing here. So other considerations. We see a high incidence of needle phobia, and probably because they've been stuck multiple times, and not just by us, but also in their other use of their general use. Aggression, violence risk, again, that's a key element of why we collaborate so closely with security and the local police. Very unpredictable behavior. And this is my favorite hashtag, I love daily dosing. And I don't think we have any pharmaceutical companies here, but we love daptomycin. Daily dosing. It's an issue with antimicrobial stewardship, I will not lie. We often have this debate with the physicians. Are they going to do, Q8, Q6, Q4 therapy, or can we just do a daily dosing, a general broad spectrum antibiotic? I know it's not the ideal in terms of for the theory of antimicrobial dosing, but for harm reduction and for that patient, maybe they'll comply and they will complete therapy. We're trying to focus on that one patient at a time. So yes, we do insert the Picc, again, could be the 7th time. We do start the IV antibiotics again, hopefully with a better regime, maybe twice a day or once a day. But we're still having that conversation with them and providing them with the education and engaging them, asking them, how can we help you comply? How can we help you complete therapy? So our venues for care and treatment, and this is now where I'm going to get into some detail about what's happening in Vancouver. This is our hospital in downtown Vancouver. We are going to apparently get a new hospital in about 7 years. This is just outside our emergency department. This is a physician, one of our physicians, again, with our paramedics, again, a very important team in terms of the healthcare team, talking to a patient, trying to get them back into the emergency department, for shelter. But our emergency department is, a lot of us refer to us as ground zero, especially our emergency department. And again, I'm showing pictures of Tanya here with her permission, and really, it's a national, it's from CBC News, so it's not like it's anything that I need specific permission from Providence Healthcare. They have a detailed team that deals with all types of patients, the psychiatry team, the security again. They're really focused on staff safety, because we accept and recognize that there's going to be chaotic behavior, there's going to be unpredictable behavior and violent behavior. Our inpatient units, we actually have a formal designation as urban health, and their focus is on urban health in terms of the challenges that they deal with. We have an addictions consult team, and we have a clinical nurse educator, and I think this is novel for the country, that just deals with substance use. So this is Tanya again, and I tried to get it to work on video. But these are photos of her helping a patient who's had an overdose in the hallway. This is real life for us. Our IV teams, when they call a code, and this is the situation we have to go. We're working with security, we're working with the paramedics, we're working with emergency room staff, and trying to deal with that patient and get them in a safe location, and give them Narcan. And from what I understand, many of you have implemented Naloxone programs. At St. Paul's Hospital specifically, we can give it without an order. So a lot of us, we know where all the kits are. And from what I understand, a lot of you still need an order to do it. Physician are giving it, etc. So this is actually what Tanya did, gave 2 doses of Narcan in a very awkward position. Like, this is not in a stretcher bay, in a nice clean room. It's happening everywhere. Sometimes I dread going down the hallways of St. Paul in the little back areas, because I honestly don't know what I'm going to find. So when we talk about the inpatient unit, I'm going to talk about some strategies that we specifically do there. And there's some things that we talk about, I think, way up in dreamland about, we're going to put tamper-resistant tape on their lines and their IV ports, and they're not going to use them. Yeah, they still use them. The pump, we're going to enable that tamper-resistant control button. Yeah, they know where that is. The supplies, we're going to provide them with sterile supplies, needles, syringes, alcohol swabs, and we do that at St. Paul's. But they still reuse. They still, wash them with tap water. They're still storing them in odd places. So theoretically, we're trying to do our best for harm reduction. So one of the local strategies that we have on our inpatient units is we have this flag that is on the chart. It's a blue diamond with a exclamation mark. And it's called Sharp's Precautions. And we work together with occupational health and safety, the nurses on this specific unit for urban health. And it's basically a care plan is set in place that identifies that the patient, A, has Sharps, B, uses them, and C, can be unreliable in terms of where they place them in the patient room. So again, harm reduction theory, we are accepting the fact that they are going to use in the room. You can't be in the room all the time. So what does that mean exactly? So when this first came out, my IV team said, well, Jocelyn, I'm not going in there because there's Sharps everywhere. And literally they're everywhere. And you've probably seen this where they're, in the bed, on the bed, under the bed, on the windowsill, exposed Sharps. And traditionally, if you told me this 10 years ago, I would have said, well, forget it. Actually, discharge the patient, right? Doesn't meet the criteria. My staff are at risk. But now with occupational health and safety and with our strong harm reduction theory, we really want to empower the patients. We involve them in the conversation when they have sharps precautions, and we say, okay, where can we agree you will put the sharps? Will you put them in this little bin on the bedside? I'm okay with that. Even if it's an exposed sharp, it could be a bloody sharp, and often they are because they've used. Will you agree to put them in the bathroom in a little bin? We just need to come to some agreement on where it's going to be so my staff are safe. And the nurses on that specific unit have been instrumental in providing this because it's about staff safety. We have a duty to provide care. We still have to enter that room. You cannot enter that room because you feel unsafe. And I think traditionally you might have been able to do that, but today we can't. At St. Paul's Hospital, we cannot. We have the sharps precaution, and we can identify the safety risks and try to work with the patient. We have a rapid access addictions clinic. So we have a problem with GPs in the whole country, right? People can't find GPs. People can't go in access some services because they don't have a GP. They don't have a care card. They've lost it. They might not know what their PHN is. They don't have that. Where do these people go? St. Paul's Hospital implemented this RAC, this clinic, where people can just go, no judgment. They actually provide Suboxone or methadone right away in order to stabilize their chaotic situation. So this, again, is a strategy that has been very successful in Vancouver in terms of getting people off the street and exposed to the risk and in a safe environment with access to the treatment that with the challenges that they're dealing with. So any of those things, no GP, no care card, self-referral, they can walk in. It's not Jocelyn, the nurse, referring them. It's not a problem. It's an open door and they're accepted. Our outpatient antibiotic therapy clinic, many of us have OPATs. Ours is a bit unique. We provide, and this may sound so crazy, but we provide bus passes, boost, and sandwiches. And our doors are there's always a lineup. People are coming, people are compliant, people are completing therapy for the most part, because of that bus pass. Can you believe that? Like, it was just this weird strategy that we thought of because a lot of the challenges are they don't have transportation. They don't have someone to drive them to the clinic to get their therapy. They don't have the money to get a bus pass. They don't have the money to get a taxi. So once we provided it, again, a harm reduction strategy, they actually came. They actually came twice a day. They actually came once a day. They saw the doctor. The ID physicians, I can't, glorify them enough. They're amazing in what they do. And we have the links to Home IV and CTCT, which I'm going to talk about. So the bridge is there. We don't necessarily want them in the OPAT all the time because we have excellent community resources. But the bridge is getting them into the OPAT and starting the appropriate therapy. So I am so proud of our Home IV antibiotic program. I think, what our program does in Vancouver, and, we have some staff here from Vancouver. We have a clinical educator specifically for IV therapy, Kathy Dirksen, who's here. My patient educator, I have one here. They are so flexible and very creative in how they provide the supplies, the services, and and if Allison, for example, says, okay, we're ready for discharge on Wednesday and something happens, some sort of chaotic event happens, acute situation happens, we are ready and flexible and creative and collaborating with the community resource to try to make it work for that patient to ensure that they get home on that Friday. But sometimes it's not about a home. Many, many people don't have a home. Part of our Home IV criteria is still, do you have, Kathy, running water, a working phone, electricity, a fridge? We have a problem in Vancouver. We have a huge homeless population. Metro Vancouver here, increased rate of 30% since 2014. And and we're not talking about the $10 million homes. I was talking to Keegan yesterday. Oh yeah, you have to have $10 million to buy a home in Vancouver. I'm not even talking about that. We're talking about really substandard housing or standard housing for people in Vancouver. There's a shortage. Where did you stay last night? This was an interesting survey. 29% unsheltered on the street. 64% in shelters. Our shelters are packed, especially if we had weather like what you do in Toronto here, where I think it was a week ago, you had ice storms and ice pellets and, I don't know what. Our shelters are at capacity. We do have a, citywide policy or response when there are extreme weathers. And, our extreme weather in Vancouver is probably nothing like it is in Toronto. But, this is something that as a province and as in Metro Vancouver, we are looking at and constantly revising and changing. So a closer look at that, though, that it's just not about addiction. They're complex medical conditions, right? If you think about the complication or the infection of endocarditis, and then you think of the substandard therapy that they received because they didn't complete their antibiotics, the worsening issue of endocarditis is a severe issue, right? Mental illness, this is something that, again, that we take for granted. We have an excellent psychiatry team and addictions consult team that work with us about mental illness and identifying and accepting that, okay, they may be using, but what are their other issues? Physical disability, that's another big thing. 52% in this survey reported that they had 2 or more health conditions. That could be anything. So the average temperature in Vancouver, 11 degrees, 10 degrees, very mild. Again, we have a huge issue with our shelters and a huge homeless population. And those of you that have come to Vancouver have seen it when you're downtown. They're everywhere. So one of our very successful strategies is called the CTCT, the Community Transitional Care Team. So the primary reason for the success is that they actually fully accept and take any type of patient. When I talk about that policy of they're gone, they've disappeared for 3 to 7 days, the CTCT will always have that door open and accept them. They will accept that, it's Welfare Wednesday, and I don't know what Welfare Day is here, but we call it Welfare Wednesday. On Thursday, no one's around, okay? Or on Friday, the Piccs come back and they're blocked. And then on Saturday, our emergency department is packed full. But the CTCT is a community strategy that is really a facility for any type of patient with any type of challenge with open access and referrals and services. So they want to ensure compliance with IV therapy. We send, a lot of patients on there to there if, the home care nursing or the home care program, home IV program isn't able to manage the type of patient. But they also provide holistic care and treatment for the client. So the thing with this, it sounds great, but they only have 7 beds. How many? 7? 10? Not very many, is basically what I'm saying. Pardon? 9 beds. There you go. So there are times where they're empty, but there are times when we have a wait list, and we are always trying to get them into the CTCT. So there's a link to family physicians, social work, an ID physician, and of course treatment services. This again, a photo with permission of a patient and one of the staff members. It is located right in the heart of downtown East Vancouver. So again, there's exposure to risk, there's exposure to repeat behaviors and safety and violence concerns. But it's independent living, and it's flexible, it's highly tolerant, and harm reduction is at the core of their practice.
CTCT is an acute care clinic in the downtown east side that provides residential care for intravenous drug users who end up in St. Paul's Hospital. Historically, the medical community looks at the drug user and will try to treat the addiction before the actual health complaint. Here, we actually address the health complaint first, and in that process, if someone wants to get to treatment or detox, we'll address that. We also provide wraparound services in housing and advocacy and healthcare. Typical stay here is 6 to 8 weeks. We have never discharged anyone to the streets under any circumstances. People leave here housed and healthy. 96% of our patients complete their antibiotics versus 20% in the hospital. It's a very good thing. We save a lot of tax dollars. There should be 20 CTCTs.
96% complete their therapy. That is an amazing statistic. 26% if they remained at St. Paul's Hospital. 96%. So one of our other linkages is a place called Crosstown Clinic. Again, harm reduction theory at the foundation of their practice. They work on goals for treatment. They look at where they're at with their drug use. They actually teach technique and vein care. I love how they call it vein care. And I've had many discussions with the nurse manager there who used to work at St. Paul's Hospital, and this is one of our sites of Providence Healthcare that's in the downtown east side. They're not currently permitted to use their Picc Line for injection. She knows all about the Picc Line, Julie, the nurse there, but you know, they're still trying to be low barrier and be very open and accepting into where they're at in their drug use, how dependent they are, how open they are to therapy or treatment, to maybe abstinence. Some of them come in and just say, that's it, I'm done, cold turkey, abstinence. Some don't. They share care with the CTCT because many of those patients on antibiotics will utilize the Crosstown Clinic. So there is an open collaboration and discussion all the time about the patients that are admitted to these two facilities. They are monitored in an injection room in terms of accessing veins. I'm just in the process of getting them some vein visualization products to help them, better IV catheters, flush solutions, etc. So that, again, provision of care, I'm a provision of sterile supplies. So that is one of our goals. But whose vein is it anyways? I think 10 years ago we would say, oh, that's mine. That basilic, that's my vein. That forearm, that's my vein. It's not. It's their vein. They're doing what they want with it. We have a duty to provide care and educate them where to stick, where not to stick. Can we start with that conversation? Don't go in the ACF. Maybe just use the hand, so everything up here is reserved for us. That's a conversation we've had. It's very difficult. I won't lie, it's a difficult conversation. When you think about your values and your judgments, it's a very difficult, but I'm teaching them, okay, just use the ones on the hand. Just, this is for us. This is for the lab. This is for me. This is for a Picc Line. As you see here, the environment is quite clean, quite safe. There's always a nurse there. There's always a physician on call. So we're reducing the harm, understanding and accepting that they're doing harm, right? But we need to remember it's just not substance use disorder. The whole picture of the patient is really important to remember. There's poverty, there's homelessness, there's mental health. And I think that is really coming up to the forefront now about the mental health issues. And in combination, when we talk about housing issues and social issues and their mental capabilities, it's really important that we look at the whole picture when we're dealing with these patients for vascular access and infusion therapy. But there are staff implications. And this is based on my conversations with the nurse leaders on the urban health units, with the nurse leaders and staff in the emergency departments, and at the CTCT, and at Crosstown Clinics. It can be challenging to care for these patients, and I'm sure all of us can agree to that. It's not an easy task. It can be very labor intensive, it can be very resource heavy, and you just feel drained at the end of the day. We need to address negative attitudes and our language towards drug use, and we need to do that in a constructive manner. We need to admit and accept what our values and our ethics are. But you need to be prepared to challenge that. And I think the staff at St. Paul's Hospital and in the Vancouver community, we're challenged with that all the time. Because I think criteria 10, 15, 20 years ago, not accepted. Okay, move on to the next patient. They don't meet this criteria. They don't have access to running water, a fridge. Kathy's, we have to change that criteria. 60% of them don't have that access. We have a duty to provide care. But we also need to acknowledge that it can be stressful, and there may be colleagues that you work with that are really struggling with this. Okay, very conservative. It may be based on a religious background. It may be, based on their previous work experience or their previous personal experience. We have to acknowledge that and try to work together to meet the challenges. But you need to lean on leadership and the resources that are available to support you. We are very lucky in Vancouver to have these resources. My goal here is to share with you the successful strategies for you to go back to your workplaces and say, you know what, these are things that are working in other parts of the country. Have those discussions with your leaders. So the future, and I talked about Crosstown Clinic, we are looking to pilot a project about supervised Picc use. How do people think about that? Everyone's like, oh my God. We're going to provide sterile supplies again, okay, that are convenient, that are readily available. Because sometimes I hear from patients, well, I don't know where that alcohol swab was, or, I don't know where that syringe was. I'm just going to reuse this. We're going to actually provide lots of sterile supplies, lots of supplies to enforce best practice and the best care. We're going to talk about education and how to teach them. So we talked about vein care, where to inject. Now we're going to talk about the Picc Line. You have a Picc Line. You want to use it? We have some therapies at the Crosstown Clinic that utilize very high dose hydromorphone and dilaudid and even heroin. We're going to, the goal here is to look at a program to teach them how to access their Picc properly, how to flush properly. I have to admit, when this was brought to me, I had red flags. Everything about it went against everything we're here about, right? But we have to think outside the box now. The trend is just going up. I don't anticipate that it's going to go down anytime soon. We have to start thinking of unique ways to deal with their vascular access, as well as when they have a vascular access, such as a Picc line or a midline or a long catheter that we've inserted, worked hard to get in with ultrasound. What can they do the least amount of harm, no exposure to the community, to our families, to our parks, to our schools, in the safest way possible? I think we're trying to find ways in Vancouver on how to do that. So the statistics show that 1 in 7 people will develop a SUD at some point in their lives. That's a scary statistic. Again, I talked a little bit about naloxone, and we do have a policy in place at St. Paul's Hospital. We do not require a physician's order to provide naloxone, and I don't know if any of you have ever given it. It works like a dream. Second dose usually, but works very well. BC is a leader in opioid addiction strategies, interventions. They just are published guidelines on how to deal with that. And this is a key document for physicians, for family practitioners, for ID physicians, for ICU doctors. So it's really about how to deal with those patients, because those types of patients, they're having cardiac surgery, they're in chronic renal failure and acute renal failure because they've injected antifreeze in their Picc. They're on the cardiac units, they're in CT scan. These guidelines are meant to help the practitioners out there as a whole that are seeing issues. So in summary, we're being challenged like never before. I really feel this. It's not just happening in Vancouver. I talk to many of you, and it's happening across the country. But we have to remember our ethics. We have a duty to provide care. But harm reduction theory will save lives if we let it. I know it can be hard, and again, I'm challenging you to think outside the box, try to put your values and judgments and how you feel ethically about these things. Try to provide compassionate care, but accepting that you may have challenges with doing it. And this is a ad campaign happening right now in BC, and I think it is extremely powerful. This is at the bus stops and the train stops and all throughout downtown. This is impactful. I don't know what else I can say here. So my intent for this, and I'd like to credit some people from St. Paul's Hospital, the substance use specialists there, that my intent was to submit the presentation for them to do, not for me, but one of them got pregnant, and one of them is not in the maternity position yet. So, but there's many others here, 2 of them that are here, Kathy and Allison. We cannot do this work alone. We cannot solve these problems alone, and sometimes we can't even solve them. So it really takes a team of many different people, collaboration, attending conferences like that, and hearing about successful and maybe effective strategies that could be impactful in your communities and in your practice. So thank you very much.
Wow.
Am I in time?
Thank you, Jocelyn, for discussing this very difficult topic and for challenging us and inviting us to think about this, because it is everywhere. Jocelyn, come to you. You're not dismissed yet. Thank you. Okay, so we're going to do a door prize now. Does this belong to anybody? It was found?
It's not a USB, it's like a little code thing. Anyway, it'll be at the front desk and it's yours.
Okay, Jacinthe Forget? Forget? All right, we're going to invite you all now to go out to the exhibit hall and view the posters and stretch your legs.